everyone. Thank you for joining us today.
The New York
The
City,
New York City Health and Hospitals, Medical and
Professional
Professional Affairs,
and
and Information Technology Committee.
It's the first
time we're saying it that way in a long while. So welcome, Dr. Mendez and the IT people. So I'd like to call the meeting to order. And
I'd also like to
note
Sally
Hernandez Pinheiro is participating virtually. We see her on camera. And she has requested the chair of the board that Erin Kelly
be
representing Deputy Mayor Ann Williams Isom will be counted as a member for voting purposes and for quorum today. All right, so I'd like to do is we do have two separate minutes actually from IT meeting as well as the MPA.
So
if I can bundle them and get a motion for approval of those minutes.
So moved.
Okay, no opposition. Excellent. Then those are approved.
All right.
And
we do have
two action items for consideration by the committee.
Mr.
Keeley, if you could read the first resolution into the record and begin our presentation.
Good morning. How's everyone doing? My name is Chris Keeley, Office of Ambulatory Care, here with a proposal for the HERC system. This is authorizing New York City Health and Hospitals Corporation to execute contracts with Huron Consulting Group, Innovative Emergency Management, Witt O'Brien's, and Indelible Solutions. These HERC project management services are with a not-to-exceed amount of $128,500,000 for a contract term of 1 year and two 6-month renewal options exercisable at the discretion of the system. What we're looking to do here is to provide project management support during go-lives and steady-state operations at our HERCs and across this body of work. This is for extensive project management support is needed to ensure smooth operations. This is a 24/7 operation that we're running across a variety of locations. And this is to do supplemental planning, strategic support, project management, really to help primarily with go-lives, to help as a new site launches, to help as a new element of the program launches, to help do the planning, do the implementation, and then the project management team phases out. One existing contract currently is being used, the Huron Consulting Services, with a historic spend of, we've committed $26 million and paid out $18.8 million through September 2023. The contract prices staff on an hourly basis, and the hourly rates include all vendor expenses. There's no ancillary costs on this, and the RFP was done to competitively bid for these services and identify additional vendors so that we didn't need to continue using an emergency contract. As with other items that we brought to the board in recent weeks, all of the expenses under this will be covered by the HERC MOU with the mayor's office. For this contract, or RFP, the minimum criteria was 3 years in business performing similar services, MWBE status plan or waiver request, and $5 million in annual revenue for each of the last 3 years. Here, substantive criteria, we had 30% relevant experience, 25% for both readiness to deploy and cost, 10% each for cultural competency and MWBE scoring. The evaluation committee included folks from operations, finance, as well as corporate health advisor from that central office team. In July, the application to issue the RFP was approved by the CRC and then posted to the city record a few weeks later. It was sent directly to 9 vendors. A pre-proposal conference was held with 45 vendors attending, and ultimately 10 proposals were received in mid-August. In late August, the evaluation committee debriefed and submitted final scores. The top 4 proposers are who we're seeking to go forward with: Huron, IEM, Witt O'Brien, and Indelible Solutions. The HERC work was originally focused on housing and wraparound services, but now we've been expanding over time to also include bodies of work like the Arrival Center and broader exit planning work, sort of case management work to help people get back on their feet and move out. The multiple vendors with various flexibility, these 4 vendors that we're seeking to contract with, will allow us to tap different types of vendors at different times as the needs of the program develops. We don't necessarily know what's going to be happening in this emergency response 3 months, 6 months, 9 months from now. So having a few different vendors gives us some flexibility on that. There's no guaranteed work assignment for any of the vendors, much like other vendors that we brought forward before. We're seeking to have 4 of them available to us, but there's no minimum guaranteed work for any of those 4. Over time, these project management services will be scaled down as new go-lives cease. So, for example, we've seen the pace of new sites on the HERC side slowing down. We haven't needed to open as many new housing locations in recent months, and if that continues on, we would phase out that type of support from the project management entities. As the arrival center continues to stabilize, we'll need them less and less in those types of spaces. Case management, however, at the broader scale that we're doing it now, that's been expanding out, so that's needed additional support from the project management vendors. Over time, as that stabilizes, we'll phase them out as well. So for vendor diversity, here you see the vendor diversity team set a goal of 35% for this solicitation. Each of them is either MWBE certified themselves or has committed to meeting that goal. You see 35% both for Huron and Witt O'Brien in that regard. Here is the vendor performance history. You see satisfactory here for Huron Consulting Group for their work to date. So we are seeking the board's approval or the committee's approval for authorizing health and hospitals to execute contracts with Huron Consulting Group, IEM, Witt O'Brien, and Indelible Solutions for project management services with an NTE of $128.5 million. Term of 1 year and 2 6-month renewal options exercisable at the discretion of the system.
Great. Thank you so much. Dr. Katz, any comments or questions?
I like the idea that we get off emergency contracts. I like the idea that all the two are 100% MWBE and the other 2 both have greater than 35%. There's no guaranteed work because we don't really know going forward that we're going to be opening very many more sites. But if we have to, then it's right that we should have good firms that are ready to help us. I fully support it. Yeah, you might have mentioned to the board that this is not out. That this is funded through our MOU with OMB. So this is not health and hospital dollars. And OMB has approved our spending these dollars.
That's right.
In terms of the tasks that they do, I mean, do they get involved, or who gets involved in the job placement or helping folks find other arrangements, and do they do some of that work, or who does that?
They support it. So that's when I was describing the broader exit planning work, that would sort of fit in that bucket. Case management, exit planning, helping families, individuals plan their exit from our housing support. And so they won't be the ones, for example, that will be sitting down with an individual having the conversation about what's your situation, how can we help you move on, what kind of obstacles are you facing, how can we help you overcome those obstacles. They won't have that conversation, but what they would be doing is helping us plan for how do we structure those conversations, how do we track the data from those conversations, how do we organize it so that we know this family got their check-in this week, but that family didn't. They help us build those systems on the front end so that we can sort of have an organized infrastructure on the front end. They help organize things like the training materials on the front end, making sure that everything's coming together on the front end so that those case managers, those exit planning staff know what resources are available. Well, we can build out sort of our internal infrastructure to supervise and manage that work. So they don't execute the patient or guest-facing services. They are sort of a step removed, helping organize it from an infrastructure standpoint.
Thanks.
Do you have any questions? Sally did actually have a couple of questions, if I can just bring them to you. And basically she was asking, she wanted to get a better sense of what constitutes project management services, those that were provided by Huron before at the outset, and then what additional, services these other contractors will bring. So I think you addressed some of that already, but if you could maybe
I did.
expound a little bit on that.
Yeah, absolutely. So the example there was just on the exit planning one. Maybe if we look at the example of opening a new site, for example, right? We've got over a dozen current locations. If we were to open a new hotel site or a new semi-congregate site in the coming weeks, what Huron would be doing, or any of these, it's been Huron, any of these project management firms going forward, we might look to them to help us make sure that all of the boxes are checked going into it. So they have helped us build out a sort of universal checklist. If we've got a family site, making sure that all the supplies for families are there, that our hospitality and logistics team is bringing in the baby formula, that they're bringing in the diapers that are needed, that we're getting the services lined up with laundry vendors that we'll be bringing in the weeks ahead, that we're working with FDNY to make sure all of the approvals are received in advance. They're going to work with us to keep that checklist and project manage while our individual sort of operational teams are doing that execution. They help to keep us organized to make sure that we don't miss any of those check boxes. And again, as we go over time and we get used to opening these sites more and more, we've been using them less and less on some of those go lives for the HERCs. And the hope is that we'll be able to stop opening new locations, and then we won't need that type of support on that body of work at all.
Her other question was related to, which I think, again, you've kind of expanded on some, but
The term
go live and steady state, she wasn't totally clear on those meanings, but it's, I guess again, if you could just, what triggers go live? Who triggers go live? And then when is decided something is a steady state where we're exiting or not?
So for sort of determining the go live, that's largely decisions driven by the city, by City Hall, right? Where they'll be saying, when they're looking at it overall, we're seeing the numbers of folks coming into the city and the need for housing increasing, so we're going to need a new location, and it's going to be for single men, or we're going to need a new location for families with children, whoever that might be. And they say, okay, let's go out and find a location, make that arrangement. And so they sort of drive the go live, the need for a go live. And then there's various agency partners who are doing different bodies of work. And so if there's a new site that might be needed for single men, maybe H&H would run it. Maybe some of our other city agency partners would run it. So there'd be those conversations on the City Hall side about sort of which agency is going to be best suited and able to succeed in taking on that new location. So a lot of that conversation happens on the City Hall side. And then if we get assigned that new site, we might engage one of these project management firms to help us run that checklist and do the go live.
I think another way of thinking of this is
we haven't hired a group of people to do go lives deliberately, because that wouldn't be fiscally very efficient, because the go lives are so variable, right? So if you said, okay, we don't want to have contractors, we want to be able to go live ourselves, then we'd have to have a team to do this. But the work is so uneven, right? You could have extreme work because you're opening, I'll say something wild, like you're opening up a site at a former Air Force base, right? So, for example, right? You would need a lot of project management, right? If you're going to have always the capability to do that, it's not going to be very efficient, right? But once we know what we're running, right, and the initial work is done, then we take it over. But I think this is the most fiscally efficient way to achieve this particular goal.
One other question then is the other firms, because Huron's obviously done this up until now. Were there any capacity issues, or were there services that the other firms bring that would make you want to choose one of them for a specific project?
Yeah, I think that as we move into the future phases, if things continue as they have been in recent weeks, if things hopefully start to stay quiet compared to where they've been, if there are those supplemental supports that we need, we might be able to transition into some of those other agencies. Huron, among those four, Huron's more of a national consulting firm, whereas the others are a little more regional. Their bench isn't as deep. The infrastructure that Huron has brought has been incredibly helpful over the last year in terms of their own internal managerial infrastructure. If we needed to ask them to bring 10 or 20 people, they would have their own managerial oversight over it that would allow us to say, here's the body of work you need to do, let's stay close on it, but they could help to execute a body of work sort of somewhat independently. Whereas some of the other agencies, we don't have as deep of experience with them. They don't have that national infrastructure. So as things move on, if it becomes, we need a gap filler, as Dr. Katz was saying, to help us bridge a gap, but we don't necessarily need the full-on sort of firepower of a national consulting firm. We might be able to execute with some of the other agencies. Some of them are a little more sort of data intensive. They're good with the numbers, moving things around. Some of them might be a little more well-suited for on-site execution or support, I should say. So I think it'll depend on how things evolve, but could definitely see the other ones getting involved.
Okay, any other questions, comments? Otherwise, let me bring it to a vote. Erin, Kelly?
Yes.
Pagan?
Yes.
Dr. Katz?
Yes.
I'm yes as well, so the resolution passes, and we can move on to the next.
Thank you.
Thank you. So that will be Dr. Davis will be presenting next resolution.
Good morning. Good morning, everyone. My name is Nicola Davis, Chief Population Health Officer, and I'm joined this morning by Emily Foote, who's the Senior Director on our Social Determinants of Health team. And we're bringing to the committee today for their consideration a resolution that would be renewing our contract with NILAG. So this is authorizing New York City Health and Hospitals Corporation to enter into a contract with New York Legal Assistance Group, NILAG, as the sole source vendor under which NILAG will provide certain free legal services to the system's patients for 3 years for an amount not to exceed $7,862,000. Emily?
Thank you, Nicola. Could we go to the next slide? Thanks. So just a little bit of background on NILAG. They're a nonprofit organization advocating for people experiencing poverty or in crisis. Their legal health division serves patients at hospitals across New York City, including at Health and Hospitals since 2002. Their attorneys address legal needs that underlie health disparities, thereby removing barriers to better health for our patients with limited financial resources. Services are provided on-site at our acute hospitals and several of our Gotham sites, and appointments are made available to residents of our post-acute care facilities as well. The current contract is managed by our team in the Office of Ambulatory Care and Population Health, and it expires on November 30th. Next slide, please. So while we have worked with NILAG for many, many years, and we have a robust partnership, we wanted to test the market this year ahead of a contract renewal. So we issued an RFI in June, a request for information. NILAG's proposal was very strong, very, very strong. A second proposal was also received, but was not nearly as comprehensive. So we were able to move to consider a sole source agreement. So in order to build on the program that now exists, a new contract will include some additional deliverables, including improved systems for closing the loop on referrals and communicating with our staff, new standards for documentation and sharing of data on patient-level outcomes, as well as participation in an ongoing analysis of the return on investment. Next slide, please, thanks. Just to give a little bit more detail on the solicitation itself, as I mentioned, we released an RFI in June in which we laid out our population health vision for an enhanced medical legal partnership program. We outlined some of the basic deliverables we would expect of a vendor, and we invited respondents to share excuse me, ideas for further innovation. NILAG's submission addressed every component of our request, and the second organization only spoke to certain pieces and would only have been able to serve specific populations of our patients. Therefore, we are now seeking a sole source contract. I will also note here that our work, Health and Hospitals work with NILAG, is supported by 2 additional city funding sources. MOIA, the Mayor's Office for Immigrant Affairs, funds Action NYC, another legal services program at 3 of our hospitals, and they pay NILAG for that approximately $1.2 million annually. City Council also provides funding for an additional 4 Health and Hospitals locations for the Immigrant Health Initiative legal services. So the services to our patients under these initiatives I mentioned are in addition to the clinics that H&H funds directly through this contract. In terms of pricing due diligence, most of the contract costs, which will increase under this contract approximately 28% from our current investment, will go to support NILAG's personnel costs. Their staff is unionized, and they recently executed a new labor agreement that included pay increases. The additional increase, in the overall cost of the contract is due to the additional deliverables that I mentioned, like the communication systems and data reporting. As a nonprofit, NILAG is ineligible to qualify for MWBE certification, and therefore they are excluded from MWBE requirements. A preliminary financial analysis conducted this fall by Health and Hospitals budget team found a positive return to Health and Hospitals among patients who received a legal health intervention. And that was largely given the number of patients who were able to enroll in health insurance coverage as a result of the legal health assistance. Next slide, please. Thanks. So just to highlight a few of the key aspects of this medical legal partnership program, as mentioned, it's been in place for over 2 decades. Our healthcare staff receives training on how to spot potentially health-harming legal needs and then how to place referrals. Attorneys are on site at most of our facilities providing in-person appointments, and we have virtual appointments available as well. Approximately 4,700 patients were served in 2022, and this year, 2023, we launched an innovative new system to manage referrals and scheduling that lives right in our EMR. That allows providers to place direct referrals, and it provides us in population health with previously unavailable patient-level data. As mentioned, while we now have a sense of the financial return to Health and Hospitals as a result of this program, our new contract does include a provision to develop a more comprehensive ROI within 1 year of signing. And lastly, we are improving our data systems to better understand and measure, importantly, the program's health impacts for our patient populations. This is the vendor performance evaluation, and as you can see, NILAG's performance to date is satisfactory. In closing, as Nicola mentioned, we are requesting authorization from the committee for a new contract with NILAG. The term will be 3 years, and it will have an annual performance review period. The overall cost will not exceed $7,862,000. And we're happy to take the committee's questions.
Super. Again, I'd like to bring first Sally Hernandez-Pineto's questions to you, and then we'll open up to the others. But she had some specific questions, and one related to just what you were mentioning about the ROI analysis. She was mentioning that it seems like obviously being able to secure Medicaid is helpful. And she was asking about other, for example, essential plan and so on. But I think you did mention actually that it's obviously not just the Medicaid, and the analysis is actually going to be, I guess, very inclusive as far as being able to determine.
Yeah, I mean, I think there's several ways in which we are planning on looking at the ROI. One of them is the conversion to insurance, but then there are other things that NILAG does, like support patients who are seeking disability and being able to appeal those types of cases. And so now you get enhanced reimbursement for those who successfully now have SSI disability. So that's, one of the other ways. So I think we're looking at all of the different ways that legal intervention can make our patients more insurable, enhance the reimbursement to H&H, and that's some of the foundation for the ROI.
It's not our ROI, but I think they're very effective with preventing evictions.
Yes.
Right, which is a city ROI, right? So it's so much less expensive to keep someone from being unfairly evicted than to get them a new home once they've already been evicted. But it's not, that one isn't on our budget.
And once they're evicted, it does become an issue for us.
Yes, it is absolutely true, right? The cost of but hard for us to track.
I appreciate that.
But it's a very, I mean, it's one of the ones I think is most powerful about what they do.
I think also just other housing interventions for health. So like asthma interventions when they intervene and
that's
can
a
get
good one.
remediation. So, and those will be able to track more closely now that we're able to kind of look at the health outcomes as well, which we really didn't have as much transparency before.
Super.
I'll just add one last thing
Sure,
because I think it's also very valuable, which is that there are patients at H&H who are hospitalized not because they need the level of medical care, but because they are not safe for discharge and require a level of service at home, care at home that they cannot qualify for without Medicaid. So when NILAG is able to intervene and get Medicaid for those patients, they can be discharged safely home, resulting often in better quality of life for the patient and then savings for H&H as well.
Yeah, I think there's so many direct and indirect components. It'll be interesting to try to quantify them all in the ROI. But another question she had was related to the median time to referral, which I believe was 42 days. And of course, that seems like a lot, obviously, if somebody is being, like the case you're just mentioning now, we don't have safe discharge and so on. You know, what's the time frame before, is there such a thing as a emergency expedited, and how does that all, and is there a way of, I guess, cutting that down to some degree to try to improve things?
Thank you for the question. It's a really good one, and I'm happy to say that one of the benefits of the new referral and scheduling system that I mentioned that we launched this year. This is actually the first time that we have any access at all to see these numbers, and it's allowing us to better track the needs. And we now have in place a foundational system to manage some of these urgent referrals with urgent slots reserved at every clinic, every legal clinic, that open up. They're only available 72 hours prior to the appointment itself. So we're able to access those for some of these more urgent cases, and we continue to refine the criteria to screen for those most urgent referrals.
Super. And I have one last question from Sally. Immigration services are the bulk of the services that you're providing, yet the securing of temporary or permanent visas is very difficult, as everyone knows, to achieve. What are the kinds of services provided by the lawyers in connection with immigration? I know it's a very broad question, but any comments there?
So I think it depends on what the patient's underlying legal need is. If they're simply requesting assistance with an immigration need, the first thing that the attorney will do is a comprehensive immigration legal screening to assess sort of what their path to residency in the United States was and what legal immigration remedies may be available, and then advise them accordingly. Some of those are, in fact, short-term visas, but there are other types of petitions that can be filed, family petitions and the like. And as I think most folks may be aware, there's an important Medicaid eligibility category called PRUCOL, standing for Permanent Residency Under Color of Law, and that does allow some immigrants who are undocumented to actually qualify for full Medicaid in New York State.
That's tremendous. One other quick question on mine, and I'll bring to everyone else, but with respect to the I guess the staff, both professional and the paraprofessional, as far as their language issue, because again, it seems more than half the patients are Hispanic. So how are we stacking up as far as, I realize we have great, unbelievable services as far as translation, but I'm just wondering, just from the standpoint of actual providers, do we have a large number of bilingual providers?
So I don't have that data in front of me. It's a good question. I do happen to know offhand that NILAG does have a number of bilingual Spanish-speaking attorneys, at least one, if not two, Haitian Creole speaking. I don't know about the secondary languages for the rest of them, but as you mentioned, we do rely on our language line to support this contract as well for translation. The language access is critically important to us as well.
Great. Erin, any other questions that you have? Dr. Pagan?
I mean, great work. I mean, important work. I had a question connected to when I hear CMS talk about social determinants, they never talk about legal benefits like this. Or so to me, when you think about ROI, the ones to convince to help us is CMS, right, or the state. So is there any movement on that, or I'm thinking about the sources of funding for this that go beyond just saying we do it to help immigrants. It's a lot bigger than that. It helps people have access. It uses maybe hospital admissions because people don't delay care, things like that.
Yeah, I mean, I haven't seen that really be a focus from the CMS perspective. They're really focused on like food, transportation, housing, and I think that there's definitely more evidence in some ways for those, and probably more ways to address it through healthcare. So I think that we're probably leading. There are medical legal partnerships in other areas, but I don't think that the ROI has been as well documented, nor have I seen the focus from it. So I think it really allows us to be leaders in this way, where we can look at the health impacts of these legal interventions. I think we're also a unique system in terms of the number of patients that we do take care of that have this as a legal need. It's one of our highly rated social needs. So I think we are unique as a system with that, but this is, I think, an opportunity for us to really build that evidence and to show it, to demonstrate it.
I'd go a step further and just say, sadly, I mean, the federal government not interested in helping undocumented people. I mean, there's no funding source, and there's no road to a funding source. Right. I mean, the conventional view of CMS, right? The M stands for Medicaid and Medicare, and by definition, these people are not eligible. And that this is just an example of an incredibly good thing that health and hospitals in New York City have done, right? And I'm very proud. It's one of the bullet points when I give talks on how great health and hospitals is, that we have a lawyer in every single hospital prepared to help people with problems like this, including immigration. Nobody else has that. Nobody else has anything near that. But I think of it as a unique New York City, thing, as a city of immigrants, that we're prepared to do this. But I think you could get CMS interested in things like helping on non-immigration issues. Yeah. I think if you showed them good data on preventing evictions, right? Because they don't like to pay for housing, right? Because they see that as an ongoing need. If you could convince them that keeping people in housing was important, I think you could get somewhere, but definitely not on the immigration one.
I mean, the kind of things I was thinking about, like, their screeners don't include legal services, as far as I know, or like making it more, like, like some employers now, well, many employers provide legal services for a small fee, so it becomes part of like the benefit package you get.
Interesting.
Thanks, that was great, thanks.
Yeah, I think to the extent the whole ROI could be demonstrated to be helpful, maybe others would be willing to.
The PruCare can be, and I know I'm looking at Donnie because I know he's helped with several of these cases. When you get PruCare for somebody who's otherwise languishing in an acute care hospital, and then you can place them in the appropriate skilled nursing facility, the financial benefit is huge, and the humanitarian benefit is huge. So each one of those cases can be worth something like, $60,000, $80,000, depending upon length of time. So when you hit one, it can be very big. The other one that tends to be financially big is if you can qualify somebody for Social Security, and there's a retro check, and it will then pay backwards the healthcare costs, right? If somebody in 2023 is qualified as having had a disability in 21, you could then go back and bill the healthcare costs, in addition to them getting a large retro check, which could then enable them to actually get housed in a way that you can't. So these are the exception, but when you get them, the ROI is very big.
Dr. Katz, are you in favor of this?
Yes, yes, very proud
I'll take
of.
that as a yes. Dr. Pagan?
Yes.
And Aaron?
Yes.
All right, if the motion does pass, thank you so much, appreciate it. Great program. Super great work. All right, let's move on to Dr. Allen for the CMO report.
Thank you. Before we go to the presentation by Dr. Basavaraj. I just wanted to highlight some of the things that are happening in MMPA, starting with clinical services operations. We're teaming up with the Office of Quality and Safety High Value to reduce inappropriate test utilization, and right now our focus is inappropriate utilization of imaging. We've also launched a patient blood management program, which should have a significant financial as well as quality impact for us. We're moving forward with shared services, a shared services model involving radiology, setting up a teleradiology reading pool, sharing MFM consultative services, child and adolescent psych services, inpatient rehab, and outpatient teleneurology, which is being led by Dr. Bell. On the behavioral health side, we've committed to opening up the inpatient psych beds that were converted to medical beds during COVID. And our commitment is to open these beds by the end of 2023. We have currently reopened 171 beds, of which 101 are actually staffed and operational. We will have a formal presentation on low-dose CT lung cancer screening, sharing with you through the equity lens our increased screening rates and the patient population that we've addressed. On the surgical side, we've increased our operational efficiency. Our volume has, comparing 2023, fiscal year 23 to fiscal year 20. Our MANO, our weekly volume has increased 13.7%. Our weekly surgery admit cases has increased 40%. Starting our first cases on time has improved by 30%, specifically 29.8. And our room utilization has increased by 12%. It's a long-term process. We're 3 years in. We have 11 facilities, 12 robots in place, and we'll be bringing 4 more on board this year as well, this fiscal year. And finally, our virtual express care has included access to medication abortions. What I'd like to do is also mention that Committee on Cancer has made site visits to several of our facilities, Jacobi, Queens, Kings, Elmhurst, all that have been successful in their accreditation by the Committee on Cancer. Bellevue had a site visit in late October. We haven't gotten the official report, but it was a very positive site visit. I want to make a special note that one of the newest members of our team, Dr. Sueed Teki, was actually promoted to clinical associate professor at NYU. And I've also included some presentations as well as publications for your review. And if there are no questions on that summary, I'd like to turn it over to Dr. Ashwin Basavaraj, who's our systems chief of pulmonary medicine. His area of focus is bronchiectasis, but he's been leading along with other pulmonary specialists in the system, low-dose CT lung cancer screening.
Thanks, Dr. Allen, and good morning, everyone. It's a pleasure to be here. This is timely because lung cancer is part of, November is Lung Cancer Awareness Month. So it's timely that we're having this presentation here during November. So I'm going to give an update on our lung cancer screening program for the system. We know that lung cancer is a deadly disease. It's the 3rd most common cause of cancer worldwide, and the leading cause of cancer death. It has more cancer deaths than breast, prostate, and colon cancer combined. And prior literature from the National Lung Screening Trial suggested that it takes 320 low-dose CTs to save 1 life for lung cancer, which is actually much more favorable compared to some of our other cancers that are out there. And despite that, it's heavily underutilized nationally. So low-dose CTs for lung cancer screening, and those that are eligible are utilized in less than 10% of patients. So we worked on a project here starting in 2021 to really enhance access for lung cancer screening to New York City and to those that are eligible. So this is based on the United States Preventative and Services Task Force recommendation for lung cancer screening, and the guidelines suggest screening a moderate suspicious population for lung cancer. So those who are aged 50 to 80, who have smoked at least 20 pack year smoking history, and have quit within the last 15 years. And that last part of the screening guidelines, quit within the last 15 years, some societies are actually removing that, which is actually going to increase the amount of eligible participants moving forward. So the proposed business plan was to enable a system-wide lung cancer screening model to offer standard of care to all New Yorkers. Next slide, please. So this was under leadership of Dr. Allen and Dr. Bell, some of our central office representatives, Albina and Jody Steinhardt, who was hired to be a program manager for the system and oversees a lot of the nurse practitioners at each of the sites who are implementing the lung cancer screening programs at each of the sites. And then this involves a number of councils, radiology, pulmonary, ambulatory care, IT, and others. Next slide, please. So some metrics that we were looking at, operational metrics, volume, revenue, and staffing, and then clinical metrics, cancer diagnosis, biopsies, and resections. Next slide. So our fiscal year 23 numbers, as we mentioned, we hired Jody Steinhardt, who's our system program manager, and then we had 3 pilot sites. So we had nurse practitioners implemented at 3 sites, and that's Bellevue, Metropolitan, and Woodhull were the first sites where we hired nurse practitioners. And the NPs are really working to see patients, contacting for follow-up when they need low-dose CTs and when they're due. So they're really, ensuring that these scans are happening. And then towards fiscal year 24, we have a number of other sites that are in the process of hiring nurse practitioners. We're expecting 10 sites by the end of the year to have nurse practitioners in place. Next slide, please. So this is some of our initial data. So you can see here in blue, this is the baseline low-dose CT numbers, follow-up imaging, lung biopsies, and that's lung biopsies from bronchoscopies and CT-guided biopsies by interventional radiology, and then lung resections. In orange here, you can see the target based on the business plan, and then in green here, you can see the actual fiscal year 23 numbers, and you can see across the board that we did better than what was expected in terms of the amount of low-dose CTs, follow-up imaging, biopsies, and lung resections. Next slide, please. And these are some of our revenue numbers. So on the top here, you can see the fiscal year 23 business plan projections. The expenses here were based on hiring nurse practitioners across the sites. We didn't reach the number of nurse practitioners initially in what we wanted to hire, but we're in the process of that. But despite that, you can see that their actual numbers here suggest that a net revenue was close to about $4 million. And a lot of that was driven through the lung resections, lung biopsies, and the images that are being performed. Next slide. So these are the percentages of the screening numbers, biopsies, and resections. And you can see here that above target, the percentages were well above the target numbers. Next slide. And this is a snapshot of some of our cancer staging based on patients that had lung cancer. So there was close to over 3,000 low-dose CTs performed as part of the screening program, and around 250 biopsies were performed, close to 100 cancers that were detected, and the number of resections were around 70. So staging, stages 1, 2, they're offered curative lung resection, whereas usually stage 3 and stage 4 ends up going to chemo and radiation. So as the program becomes more robust, we're hoping we see more of the stage 4 cancers become stage 1 and stage 2, where we can offer earlier detection and offer curative lung resection for those patients. Next slide.
Maybe just for people who are not physicians or nurses, just to reiterate that the screening program only works if you can find the early cancers, because it's not a great service to someone to tell them that they have inoperable lung cancer, right? Maybe it helps a little bit in planning the rest of their life, but there's not a huge rush to learn that you have cancer that can't be operated on, because neither chemo nor radiation is particularly effective it's mostly palliative. So the saves are when you can find the 1 and 2, because if you can resect lung cancer, you usually have a cure. So the whole determination of the efficacy of this program is focused on the ones and the twos. How many people do you come up with, rather than the way most screening tests would, you'd like focus on the number of positives you got, right? But in this case, it really, the whole focus is on who has resectable disease, because that's all that really matters.
Can I ask you a quick clarifying question? Of the people 50 to 80 that fit into the definition that you explained earlier,
Yeah.
how many of them show up for screening or get screened?
Well, really, it's up to the providers to offer screening, right? So patients are not coming to the, to the office and say, I want to screen. They're coming because of their general checkups. They're coming because they want to stop smoking. So it's up to the providers to really recognize what the guidelines suggest and then offer it to the patients. So it's really, more education to the community, to patients and to the providers.
I guess I'm
really
trying
offer this
to
program.
find out how many people were reaching out that should be screened, going back to what Dr. Katz was talking about.
Well, the other, just sort of to just generally understand the landscape, this technology has not been uniformly embraced by primary care and generalists. And it's not, I mean, I think part of it is that we haven't had data like this. The concern, which is totally justified on the case of generalists and primary care doctors, is that, is this really a effective intervention, right? I mean, the true effective intervention is stop smoking, right? And of course, some of the best candidates for these have stopped smoking and need it because of, they've already stopped. So you've already done the most effective thing. But I think a lot of people, one thing they'd say is, why aren't you spending more money trying to get people to stop smoking? Wouldn't that be more effective than spending your money on advanced tests? So that's one argument that has led to less enthusiasm. And I think now there's more understanding. There's been concern about, of course, you're radiating people. It was never a great idea to radiate people to prevent cancer, because radiation causes cancer, right? So I think the sort of low dose issue has become a little bit more prominent. In general, the radiology is getting better and better at directing the radiation so that people get lower exposures. But I think that's been an issue. I think there's been some suspicion earlier on about that this was being promoted by the companies that make the CT scans, that they were really pushing this hard because, they make money selling the scans. The scans are difficult to read, right? I mean, it's not a simple, right? There's a lot of radiology time involved in reading the actual scan. So, I think that data like this in a public system can really help define what is the benefit, and that if people, if you move the generalists and the primary care doctors to feel, because, we have very high rates of mammogram screening and of colon cancer screening, much higher than this. And it mostly reflects that the people who are ordering really believe in that and haven't been entirely sold yet. And again, it's not a laziness, it's a question, right, that they're facing when they see their patient. How of the things they have to do, how valuable do they think this is? How good?
Can I ask you something to both of you, more anecdotal, right? I hear people with secondhand smokers get lung cancer, because I've seen cases like
absolutely.
that. So in a city like here, where we live in enclosed spaces,
Yeah.
you're in your 60s or 70s and you're exposed to your spouse, or
Yeah.
how does that fit into the definition that you explained earlier on the screening? How do you screen those?
You screen them. So, patients who.
We'll get reimbursed is always
So
the
they count in the definition, the physician would know?
So if a provider says, my father, for example, smoked, every day of my life until I was 20, right? That's significant, right? That's significant secondhand smoke exposure for a number of years. They're at risk for developing malignancy. So those are, patients that would say, hey, let's go ahead and screen you, because you are at risk for it.
So the guidelines are good enough to to capture those. They're sophisticated enough.
I don't think the guidelines.
Not
do
the
it.
guidelines.
You would just be using a sort of off-label, if you will.
Off-label,
You would
yeah.
be making a clinical judgment.
On that.
And I don't know whether or not the insurance would pay for it. It would probably depend on whether or not they had a savvy enough system to figure out who is who. If they do, they're not paying for it. But sometimes, as you know, it's too difficult for them to figure out who has this quality and who doesn't, and so they just assume that the doctors are following the guidelines.
Yeah.
Depends.
I have not had it denied. So I've had specific patients where I've sent them for screening CTs and they've had it performed. So I haven't had it denied.
Thereby proving that the insurance company doesn't have a system to deny it based on eligibility.
There you go.
It's one other question. I apologize. I don't want to interrupt the flow, but just since it's germane to these issues. So let me just get clarification though. So Dr. Katz in the office, patient is totally asymptomatic, but 20-pack a year and so on, is actively or stopped recently smoking. He's referring to this program. He's not necessarily directly ordering it. And how does that work? Tell me
that's a great
the
question.
mechanism of how
That's a great question. So this is a model that we've been talking about within our pulmonary council. You know, what's the best way to refer? Would we want to have a direct system where we refer a patient to the screening program, or do we want a hybrid model saying, hey, does primary care want to order the scan or give them the option to directly refer? And actually, primary care wants these patients. They want to keep these patients because they feel that screening, you know, is part of their responsibility. So, our primary care, our ALCL council approved a hybrid model for the system where, you know, they can order the screening CT themselves. If it's abnormal, they can then refer to, you know, the screening program, or they have the option to directly refer. So we're leaving it up to primary care to see, you know, which way they want to, you know, go down that route.
We mostly order. So, and it's no harder for me to order this than it would be to order a CBC blood test. I mean, it's you know, it's the same number of, it's very simple. I think the hard parts are explaining to patients why they need to do it.
Right.
And then, of course, if it's positive, then it's very complicated, because then you're talking about someone who now either needs surgery rapidly, or they need chemoradiation and a long talk about, you know, planning for end-of-life kinds of issues.
And going back to what Dr. Katz said, that discussion with the patient on whether to perform a screening CT, that's called shared decision-making, which is actually billable in and of itself, and that's not actually being captured in the revenue data that we presented here today. So that's something moving forward. We want to actually link that to the CT order to see if we can capture shared decision-making for all our patients. And just finishing up here, just a few more data slides that I have here. So our catch rate per se was 3% on our lung cancer screening program, which is slightly higher than the national average. Next slide, please. And then this is just the percent above target in terms of reimbursement. You can see here that our percentage for screening CTs, follow-up imaging, lung biopsies, and lung resections was increased across the board. And just to highlight with the lung biopsies, we actually implemented robotic bronchoscopy last year, and we were the first site in the Northeast, a public hospital site in the Northeast, to have robotic bronchoscopy at Bellevue, which is something that we were particularly proud of. And that actually uses computerized software to get to a lung nodule, which is otherwise difficult to get from a traditional bronchoscope, and allows us to stage during that same procedure. So it's something that really is state of the art, and we have available here in our system. Next slide, please. So our net revenue above was 200 above target. Next slide. And just our last data here. This is some data from our tobacco registry dashboard, which is a subset of patients from the lung cancer screening program, but tells a nice story here in terms of who's getting low-dose CTs in our system. And you can see here that it's quite diverse, the race and ethnicities. You can see about 23% of African-American patients had low-dose CTs, 25% Hispanics, 24% white, and 26% Asian. And 19% uninsured, 20% Medicare, and 20% Medicaid were part of who received low-dose CTs. And that's really unique about our program. And this is not really well published in terms of the public hospital system and lung cancer screening. So this is something that we submitted for publication in the American Thoracic Society, and we're waiting to hear an answer on that. Our screening rate also was 24% after implementation of the nurse practitioners at our 3 pilot sites, and that's well above the national screening average of 6%. So that shows us the utility of having this nurse practitioner model and increasing the amount of CTs that are being performed. And then finally, you can see here that of the low-dose CTs that were ordered, it increased by 10%, the completion rates with having nurse practitioners on board. So again, showing the utility of having nurse practitioners follow up on having the orders completed. So some good initial data from the program, something that we're excited about, and hopefully improves moving forward. And then just finally some final events here. Next slide, please. So we have, obviously we're going to be embarking on an educational campaign for lung cancer screening. We have some educational CME series. We mentioned Lung Cancer Screening Awareness Month, and we have a lung force walk for New York City Health and Hospitals in May of 2024. And then our last slide here. So our fiscal year 24 numbers, our 24 goals is to continue to create a robust lung cancer screening program, offer education and engagement to our community. We're going to enhance our EMR. We have an Epic model, Radiant, that's going to be coming out. That's going to really capture a lot of the data that we're talking about and really capture more patients moving forward as part of that model. So something that we're going to be working on with IT. And then our goals, once we have more nurse practitioners in place, is become a designated site for lung cancer screening from the American College of Radiology. So something that we're going to put an application for in the near future.
Fabulous. So on that next to last point you were making about the identifying the patients, so having accurate smoking history and so on, is that something that can then be captured and that information can be flagged basically to the primary care, which, as Dr. Katz says, hasn't been overwhelming? Appetite for whatever reason, although I think you really mentioned some of the reasons.
What do you think, from your experience in more of the private sector, do you think most practitioners are on board, or you think there's still a lot of...
I think you identified it exactly across the board. I think in both, I think certainly in the private sector, the same issue. And I think a lot of it is the exact things you mentioned. Well, wait a second, CT, isn't that a lot of radiation? And what are the long-term effects and so on? And we don't have great smoking histories. I think this issue where you'll be able to identify people and get accurate information will be tremendously helpful. But, it's one of the things that goes in your social history or whatever, and smoked, not smoked, if somebody's not complaining, I think that's the problem. As you said, by the time someone has hemoptysis or is losing weight or whatever, they're stage 4 at that point. We've lost that, and so they'll get their CAT scan, but
I think people also don't really like admitting how much they smoked. I think that's also, even when you ask people how much they smoke, I think they underreport. So, the doctor can't you can only, if you ask someone how much they smoked and they said not very much, because it's not considered socially appropriate to admit that you smoked, right? So, I do think that even the data, when it's correctly entered, isn't necessarily fully correct for the risk of smoking.
Right. Yeah, but you do have some patients that want the CTs, right? They say, even if they never smoked at all, right? I have patients that say, can I get a low-dose CT because I just want to make sure everything is okay.
Yeah, my experience has been there's not a lot of difficulty, as you say, in this joint decision-making. It's like, well, I think one of the issues, though, would be having it done every year. That's something that some patients might have. And for the same reasons as primaries have issues about, again, the radiation exposure, I think to get it into being like a mammogram type of mentality that's going to be a little bit tricky, but I think that initial screen certainly is not hard to persuade people.
Yeah, and some programs also tie it into to mammograms for breast cancer screening. So as they go for their mammograms and say, hey, if you're a smoker, you may be eligible for a low-dose CT, you should consider getting it. So that's one strategy that we can do to try to offer it to more patients.
On the rate that you show there, the one from 47 to 57, the use of the CTs, LDCT. I was listening to Dr. Allen earlier on her report talking about how they had this pool of radiologists, and I was wondering if that, what was driving the low rate? Is it that people, you cannot schedule the appointment on time, or does that help?
There's a number of reasons, right? Patients following up and getting the scans. It's not so much getting an appointment, it's really just the patients following through on the order that's being placed and, forgetting about it, right? Some patients may say, I totally forgot about it. So the nurse practitioners really can contact patients and say, hey, as a reminder, you're due for your low-dose CT. And they said, oh, I forgot. So that's probably one of the driving factors there.
And the EMR enhancement that was referenced, part of that is the automated reach out to those patients that have a CT order, reaching back out to them in addition to the nurse practitioner, but you can automate some of that as well.
Thanks.
Aaron, any questions on your end? Have we got anything else? Katz, any final comments?
Nope.
Great work. So thank you for that. Appreciate it. All right, let's go on then to our chief nurse executive report.
We should make sure we leave enough time for IT, just so that on our first meeting that is
Exactly.
combined, we don't.
So
make
what Dr.
IT
Katz
feel
is saying is that
right?
both MetroPlus and the, actually MetroPlus is the very end, but in either case, try to, I guess, see if we can capsulize. And reality is a full report is always included for public
Correct.
record. So that is available. So again,
I'll breeze through my report. My name is Albert Bolaro. I'm here for Dr. Natalia Sinias, here to report on several slides, but we will be fast on this. The major report, I think, would be the nurse residency program celebration with the mayor's office. It was done on the 24th. It celebrated the participation of New York City Health and Hospitals in the citywide consortium for nurse residency programs, and it was done at Couvenir Hospital. Next slide. There were several people who spoke, including deputy mayors, Dr. Sinias, and one of our residents who shared her experiences in the program. We are also doing a doctoral circle of excellence, mostly to capture who are doctorally prepared nurses in the system, to get them to be accessed by the work that they've specialized in their doctoral preparation. Next slide. Dr. Katz was speaking in the program along with Dr. Sinias, and several new graduates from the doctoral program also spoke. Next slide. Respiratory Care Week celebration was held recently. The guest speaker was Dr. Mukherjee from Bellevue. Next slide. The care delivery model is in implementation mode this year. The most recent ones are Queens and Metropolitan. Dr. Sinias is at Elmhurst today, which is the reason why she couldn't be here in person. Next slide. Our fireside chats are going on. These are FaceTime interactions by the nurse executive with our frontline staff on specific topics. The focus of the last ones were mostly on the new contract with New York State Nurses Association. The Magnet Conference we attended in Chicago, October 24th. There are several slides to this, but I just want to say that we had a big footprint there in that conference. We had 7 podium presentations and 14 poster presentations. Next slide. These are the list. Slide. We are having a Nurse Excellence Award ceremony on November 30th. That's coming up. Next slide. There's a new pressure injury prevention guidelines rolled out. Next slide. Shared governance is still active and ongoing. Nurse residency program is continuing and ongoing. The mentorship program is also happening in partnership with Human Resources. We have graduated a total of 440 behavioral health associates. We have a learning management system that was launched recently. Next slide. We have started an emergency department nursing fellowship. Next slide. That's it. Thanks so much.
Thank you for your brief presentation, but not to underestimate the importance. I think nursing has been just outstanding. It's just amazing to me over the last few years, what you all have accomplished, and I kudos. I mean, just tremendous work, and I appreciate so much.
Agreed.
Any other questions or issues? All right. Welcome, Dr.
Thank you very
Mendez.
much. Oh, yeah, here we go. We can go to the next slide. Kim Mendez here, CIO. I'm also joined by Dr. Michael Boughton, our CMIO, Jeff Lutz, our Chief Technology Officer, and Catherine Thayer, who leads our clinical applications, including Epic. Our report is here, but I just wanted to highlight as part of our report, as we're new to this committee, I have included the updated table of organization, as well as our fiscal year 2024 goals, and we can move through that. And then a little more detail on who in my department, leads each of those different areas. Our goal today is to highlight 3 key areas, if you will. One is over our infrastructure and telecom. We can move to the next slide, please. Oh, I also put in, Dr. Calamia, our governance structures that we have. So all of our different governance committees, I will highlight here that one of the new ones that we've had is our Biomedical Device Council. This is a significant area for us, particularly from a cybersecurity perspective. When we look at those different devices, we liaison with data and analytics, and the newest one is our AI Council, which we are in partnership with data and analytics, and we have just launched this, and we can bring more on that. We've had our initial meeting with a charter developed there as well. Lots in that area to unpack. Just wanted to bring up the board up to date on our data center migration. We have, you can see that our timeline is, very fast approaching next month. I will say that we have made a full complete transition from SunGard to QTS, which we completed actually last year, September 2022. We are on track to complete and on budget to complete the second transition, which is from our Jacoby site over to CyrusOne, and right now we're around 96, complete. If you probably get a lot of emails with messages on moving the DMZ and other things that are happening, that is part of this major transition that's going on. We call that move waves, and we are finalizing those in particular. So the next time that we meet, we will be fully engaged in both of our 2 new data centers, and that has been a significant lift, I'll say, for both the infrastructure team and any of the service line areas, because it's a team effort to move all of these different applications and set up the structure. The next slide this is a more graphic representation of the same timeline. The other area to highlight is our audiovisual contract that we just completed at the last board meeting. The significance here is that this will actually help us with cost savings across the entire enterprise. This is for audiovisual equipment for training rooms, auditoriums, the emergency management services, et cetera. But instead of having different, applications or software across at each facility, we now have an enterprise solution that everyone can take advantage of. So it also helps us with cost savings as well as it standardizes our implementation. Just wanted to highlight that. The next area, actually, Catherine, I'll turn over to you here, is some of the major efficiencies and functionality that we have brought both to Epic as well as clinical applications. And maybe a quick overview.
Sure, thanks, Kim. So one of our goals is to really utilize our EMR to the best of our ability. So we've been doing that by upgrading the foundation that Epic sits on to be a little bit faster. That's the Epic Hyperdrive, so it's essentially a new browser, if you will, for Epic. We've also been working on how we can support the downtime, so making sure that we have better workflows and documentation tools while we're down. That's the business continuity access web data entry, so being able to document admissions and transfers while we're in downtime to make for easier reconciliation. Next slide, please. Thank
And
you.
I'll just pause on the business continuity. That's also an area that we test, if you will, when we do a tabletop exercise for cybersecurity in the event that we may need to go to downtime. So we're putting that in our training as well.
Yep, and then for this one, the first one there, the biomed device database. So like Kim mentioned, this is a really big area for us. The teams have been actively working on getting that database up and running so we can have better tracking of the devices and also better scanning for security. And outside of that, we have other ongoing implementations with Omnicell and utilizing our Dragon licenses. Thank you.
And the third area that I wanted to highlight was around ETIS customer service, some national benchmarking and training. We can go to the first one, which is around enterprise support services. This is kind of like our unsung hero. This is the individuals who you pick up the phone and try to call them if you need to reset your password, etc. But I did want to kind of highlight that they get an average of over 55,000 calls and 8,000 emails, and then other calls throughout each month. We can go to the next slide, which actually shows our customer satisfaction score. So what we do at the end of the call, we'll send out, how did we do, as a survey. The national, we're right around 92. We have stayed above 91 and 92 for the last year. You can see each of the volumes of calls on each one of the months. The national benchmark is 85%. So we are actually benchmarking against ourselves at this time. I will also say that we do provide not just internally to ourselves support. We do our enterprise support services also helps with MyChart set up for patients if they need assistance, and they can call the same number or they can email us for that. The next area, I'm actually going to turn over to Dr. Michael Boughton, which will look at our EPIC Gold Star. This is our national benchmarking, as well as the class report, which shows how we're doing with the experience of our electronic health record based on our individual end user responses.
Thank you, Kim. Yeah, so most of the work we do is responding to the needs of our clinical councils, our end users, everybody within our organization. But part of what we want to do is really make sure that we're benchmarking ourselves appropriately about what's available out there in the Epic ecosystem. And what this slide is showing, that we're in the top 25, top third of the country nationally on the features that were adopted. So this is one of our external benchmarks that we hit over the past summer. I can share with you that this past week, we hit the other Epic program, which is called Honor Roll. Once again, about the top quarter get it nationally on that. That's more not what features are available, but how you're actually implementing them and using them. So it's kind of two sides of this, a very similar coin. But those are Epic external benchmarks. Very happy that both show us in the top quarter nationally. If you can go to the next slide. The Arch Collaborative is a group of, I know this slide says 264, it's a little bit outdated. We're up to 300 organizations across the country now have participated in the Arch Collaborative. And what it is, it's a standard question bank it's a survey that goes out to your own providers, your own nurses, and they rate how you're doing as a system. So even though this is an external survey, it allows us to benchmark ourselves against how other people have done. It really is a response to how our people think we're doing for our IT infrastructure. And if you can go to the next slide. I'm pretty happy with the results. So what you're seeing here is that overall, we finished in the 86th percentile nationally across all users, and of similar size organizations and that share features with us, we're in the 80th percentile. So what I'm seeing here is both on external benchmarking and on, really, this is what I would call internal benchmarking. We have a top of the line electronic medical record and IT infrastructure, which I think this is there's certainly areas to work on. We are continuing to add gold stars. We are taking feedback from our end user surveys to try to make our system better. But this was a gratifying result to have received. And what this slide basically shows is that it's not just our physicians are happy or just our nurses are happy or just our allied health. It's across the board. The right side of the screen here is all how we did at H&H, and the left side is the national benchmark. So across all different service areas, we are above the average significantly.
And the last area I wanted to just highlight is the training that we have done in EITS. In October, we had a major campaign on cybersecurity. October is Cybersecurity Awareness Month. And if we go to the next slide, one of the things that we, when we first rolled out Epic, it was really what was Kevin's crackers and water. That was his terminology. We get the core down and we get it across our system, so we standardize it, and then we can go back and build on top of the core. So we call that now the Thrive program, and that is an opportunity you can see here that we have held, and we have launched these technology fairs on site, in person. It can be one-on-one, you can schedule time, or you can walk right in. And this has been focused primarily on providers, this particular one around personalization. Also using, you can see on there is Dragon and Haiku if you need assistance with that. So we've completed three different facilities, sorry. And then we have a plan to move forward with all the other sites throughout the end of this year, as well as into 2024. This has been extremely well received. I will say I have actually received calls and emails back from the providers, and it has been a welcome. And if anybody internal here in central office would like one, we will be happy to set that up as well.
We certainly never would have survived COVID transfers were it not for Kevin's crackers and water, because otherwise we wouldn't have all been on Epic at the time COVID hit. But I also would say, just as a user, that I wasn't prepared to learn all the things I can learn about how to use Epic when I first started to use Epic.
Like your phone.
Right. That you kind of have to interact with it a bit to understand what it is you can't do, and that there are easier ways to do it, because it's too much, or at least it was to me, too much to absorb. I had to get to being able to chart a patient, do my orders, have a medicine list, right? And now, having done it, periodically I make some new leap into doing something that makes it easier for me. But it never could have happened for me at the beginning. I never could have I wouldn't have been able to absorb it all.
One of the results of the ARCH collaborative data that went out was that, echoing exactly that, is that our providers and nursing are actually asking for more training. And this was part of that response. So we got those results of this summer. We had the suspicion that was going to be nationally. People actually want more training on the electronic medical record. And so this is part of what we're providing. We've always offered a virtual ability to come in, but this is the in-person, which I think just adds a nicer touch. Some people that need the help with the electronic medical record will do better with in-person, so that's what we're offering.
And it's so much easier if the provider sets up their own personalization of things that they frequently use, that makes it easier for them to document, et cetera, or order, particularly order, I believe. The last area, which we can close with this one, is just highlighting some of our amazing employees. This was actually on the intranet. This is the South Brooklyn Health Team, previously known as the Coney Island team. And this is the team that helped, from an IT perspective, launch, that new facility. And I think that closes us out. Thank you very much, Dr. Calamia.
Thank you so much. Dr. Pagan, any questions? Dr.
Nope.
Yes, comments or not? You are here. I was looking around the table. Who is going to be giving this Metro Plus report?
Maybe, especially because time is short, talk about your success in re-eligibilizing people, because I think of all the things you've been doing, that has the greatest impact to us.
Sure. So you see some of the numbers since the redetermination took effect back in June. So we initially were hoping to get to up to 85%, but that was a little ambitious. So in general, what we're seeing across New York State, who is the leader really in redetermination success, is success rate of around between 78 to 83%. That's the range. So we fit nicely into the New York State kind of benchmark. And that takes a lot of effort. We have multiple teams who are working on redeterminations, and there are teams at health and hospitals who work on redeterminations as well, and we work together. So we have a team dedicated. That's all they do. They make sure that people stay covered, and this is the customer success operations. Our sales team, who initially enrolled those individuals stay on their dashboard. It's a state dashboard. And so the sales team is not just selling and trying to bring in new membership, but they are also responsible to redetermine the members they signed up in the first place. And then, obviously, the financial counselors on the H&H side are working on the people they signed up in the first place. We have an interplay between all three groups, where if one group gets tied up for apologies for whatever reason, the other teams can jump in and help with the redetermination. We're also working closely with the providers. Some of the providers obviously have very close relationships with their patients. So where we see significant volume of members slash patients attached to a provider, we work with those providers as well. We provide them up-to-date information. The rosters of people who need to be redetermined are available on the provider portal. And we frankly offer our resources to be deployed into their offices to help with outreach to members who have not certified. We're also working with CVS, reminders on the CVS packets for people who need to redetermine. There are obviously a lot of outreach efforts to the members. And then we're working with various CBOs. There is a number of CBOs in the community who have enrollers, and so they enroll some of our members, and so those members are on their dashboard. So we're working with those CBOs to make sure that they're successful with redetermination. So it is certainly a very multi-pronged approach to make sure that we are capturing as many eligible individuals as possible. We have done well. These numbers are showing not final numbers through November. We are starting to see some decline, which is expected, right? Because in the end, we are redetermining 80%, which is high, but it's not 100%. A lot of people are now employed. People left the state. There are various legitimate reasons of why people would not stay covered after the moratorium. So we are starting to see some decline. It's slow. It's slow and it's predicted. But I think all of the efforts that we have put into place and are still putting into place, and they will continue over a period of 14 months, that's the unwind period, are yielding good results for the system.
Do we have some sense of how many of those that no longer qualified for Medicaid are now going on to other programs, and then we retain them? Do we have any sense of that? Or?
Yes, we have a significant movement from Medicaid to the next level, which is the essential plan. Huge, more than ever before. So yes, a good portion. The number, though, here reflects the entire kind of enterprise. So it captures people who move to other lines of business. So the 80% is people who stayed somewhere in any kind of line of business within the plan.
Thank you.
Any other? Let's jump to quality. So some good news to share here. We are in the top tier for our MLTC program. Tier 3 is the top tier for MLTC. And so we're very proud that we landed at the top tier. And we're particularly proud of the metrics that you see in the third bullet point, where members reported high level of satisfaction with the quality of their care managers, upwards of 96%. Rated their experience as good or excellent. And these people really need pretty close interaction with the care managers. The care managers make sure that all of their needs are being met, that the aides are showing up on time, that their services are being rendered. These people have significant and complex needs, so it's particularly important that they get them in a timely fashion. And then on the next slide, you will see that we also ranked as #1 for our HIV SNP program. Again, very proud. We have approximately 10,000 people in this program. And the most important metric there is the fact that 82% of HIV positive members had no detected virus in their blood. I mean, this is what we're really, really, really working hard on. And 82% is natural. It's a difficult population. Some of them are hard to find. A lot of them are homeless. So 82% of undetectables is something that we are particularly proud of. And then if I have 2 minutes, I will just mention very quickly some of the enhancements to the member experience. We introduced member health. We know that there are issues with transportation sometimes, not showing up on time, not showing up at all, and members are not able to make their appointments, sometimes critical appointments. At this point, we have Uber Health, which is kind of a backup transportation in case there is any kind of delay or no-show with our vendors. We also currently have ZocDoc, where we are able to schedule appointments online for our members who are also contracted with ZocDoc, and we're working on doing the same for H&H through Epic, and this will launch in the next quarter. Next slide. And then we just introduced a new AI tool. It's called EliQ, and essentially it was distributed to elderly adults to tackle loneliness and also issues with adhering to their plans of care and interacting in general. You can upload any kind of information you would like, either from the provider or from the caregiver or the patient themselves. And EliQ essentially interacts with the patient throughout the day, make sure they're not lonely, but also reminds them of various things that they need to do, taking their medications, going to appointments, eating, drinking, whatever the need is. So it's in place. So far, so good. It has been deployed into patients' homes, and we're hearing very positive feedback so far.
Fabulous. So it'd be interesting with REHR as far as the schedulings for the ZocDoc equivalent. I'm just wondering how far along we are with that, and is it because that would be allowing the members themselves to make appointments directly in the system, right? And
right. So
that's pretty advanced.
I had that same question.
Yeah, it's a very advanced situation.
Right. Is that available already, where members are able to schedule their first appointment? Right.
Through MyChart, we allow scheduling for
okay.
many different service lines, including primary care and subspecialties. It's not universally on all of them because there has to be an agreement from both the clinical side as well, but the majority at this point can do that.
So for MyChart itself, they would have had to have a visit already in our system, though, no? Or
it's a good question. So you don't necessarily have to have visited. You have to have signed up for MyChart, and then we are putting in the ability to schedule outside of MyChart, but that's getting ahead of ourselves.
Gotcha. Okay, super. Any other questions, comments, new business? There being none. Thank you. Have a wonderful Thanksgiving.
Thank you.
Thank you.
This meeting is no longer being recorded.
Thank you.